Hello everyone and welcome to our module on gastrointestinal secretions. The most important secretory product of the stomach is gastric acid, and gastric acid is secreted by the parietal cells in the stomach. These are found in the gastric glands. I'll show you a picture of that in a minute. And the parietal cells secrete hydrochloric acid, and that's what's responsible for the very low pH in our stomach. Our stomach is a very acidic environment. The pH is usually less than 5 and it can get as low as 1. This very low pH is important for a couple of reasons. First of all, it protects against infectious agents. So any bacteria that get into the food we consume are usually killed by the low pH in the stomach. And then in addition, it denatures proteins. So as you may know, proteins are globular three-dimensional structures. And when they're exposed to a low pH environment, they begin to fall apart. And this begins the process of breaking down proteins so they can be absorbed into the body. Now you may wonder, with this very low pH that can kill infectious agents, why it doesn't kill the cells lining our stomach, and that's because they are protected by mucus and bicarbonate, and these are secreted by other cells in the stomach called neck cells. Shown at the bottom of this slide is a picture of the mucosa layer of the stomach. This is the muscular portion of the mucosa layer. The epithelium lines the top, and everything in the middle here is the lamina propria. And all these channels and cells in the middle here are called the gastric glands because they secrete gastric juice into the stomach. And if you look in the zoomed in picture over on the right, you can see that there are channels within these glands that deliver gastric juice to the stomach, and the channels are lined by different cell types. And one of these cell types is this pink cell type right here, and that is a parietal cell. Parietal cells are eosinophilic, so they appear pink when you look at them under the microscope. They're found within the gastric glands, in the mucosal layer of the stomach, specifically in the lamina propria portion of the mucosal layer. And there are more parietal cells in the upper portion of the lamina propria. You can see how there's more pink in this portion of the slide than down at the bottom where there's less pink and more purple. It's very high yield for step one of the boards to know the physiology of acid secretion in the stomach. So let's start that discussion by going over the different stimuli for acid secretion from the parietal cells. The first stimulus for acid secretion is the hormone gastrin. It can directly activate the parietal cells to secrete hydrochloric acid. Gastrin is a hormone that comes from G cells in the antrum portion of the stomach. That's the distal portion of the stomach close to the duodenum. And gastrin can bind to a receptor called the CCKB receptor on parietal cells, and when it binds, it triggers them to secrete hydrochloric acid. Gastrin can also exert an indirect effect on the parietal cells. It can activate intermediate cells called enterochromaffin-like or ECL cells, and when gastrin triggers these cells, they release histamine, and then the histamine stimulates the parietal cells to secrete hydrochloric acid. And as we'll talk about later in this module, there are acid-suppressing drugs which are antihistamines that block this gastrin-induced stimulation of the ECL cells. And then the final stimuli for acid secretion comes from the vagus nerve, which is part of the parasympathetic nervous system. The vagus nerve can release acetylcholine, which can bind to muscarinic M3 receptors on the parietal cells and stimulate them to secrete acid. In addition, the vagus nerve can activate G cells to secrete gastrin, and then the gastrin can go and exert these two effects on the parietal cells to promote acid secretion. Now, there's a peculiar feature of the way the vagus nerve activates these G cells to release gastrin. It does not use acetylcholine as the neurotransmitter. Instead, it uses an unusual protein called gastrin-releasing peptide, or GRP. The reason this is clinically important is because if you block acetylcholine, you will not block the vagus nerve's effect on the stomach because this GRP will continue to function and it will stimulate acid secretion. So decades ago, before we had medicines to suppress acid production in the stomach, patients could suffer from severe and potentially fatal peptic ulcer disease, and sometimes those patients would undergo a vagotomy where the vagus nerve supply to the stomach would be surgically disrupted, and the result would be decreased acid production. And you should understand this based on what we just discussed on the last slide. If you cut the vagus nerve, you cut this mechanism of stimulating acid production, so there's no acetylcholine release onto the parietal cells, and there's no activation of the G cells and gastrin production. Therefore, you decrease the amount of acid in the stomach. Now, luckily, we don't have to do that anymore because we have drugs that do this, but if you meet people who were alive in the 1940s, 50s, and 60s, they probably know people who had a vagotomy in order to blunt acid secretion. You also should know that atropine does not work very well to suppress acid production. It's a muscarinic blocker, and it can blunt parietal cell stimulation by acetylcholine, but it doesn't block the stimulation by the vagus onto gastrin, which can then stimulate hydrochloric acid release. As I just told you, that occurs via the neurotransmitter GRP, and it's high yield to know this for your boards. They like to ask you why atropine doesn't work to suppress acid, and it's because the vagus nerve is still able to stimulate gastrin release even when muscarinic receptors are blocked by atropine. I won't talk about this in detail, but in addition to their role in producing acid, the parietal cells also produce intrinsic factor. This is necessary for vitamin B12 absorption. It's released by the parietal cells along with H+. I talk about this in much more detail in the modules on B12 deficiency. So now let's zoom in on one of those parietal cells and talk in detail about the physiology that's occurring to generate all that acid in the stomach. So the first thing you should know is that there are separate pumps in the membranes of parietal cells that secrete H+ and chloride for HCl. So there is an ATPase pump which pumps out hydrogen ions in exchange for potassium, and then there is a separate channel by which chloride is secreted into the lumen of the stomach. And there are drugs that are called proton pump inhibitors that inhibit this hydrogen ATPase and block H+ secretion. Those are drugs like omeprazole and pantoprazole. I talk about these in more detail in the module on GI pharmacology. The hydrogen ions that are pumped out into the lumen of the stomach by parietal cells are formed by the enzyme carbonic anhydrase. Carbonic anhydrase takes molecules of water and carbon dioxide and converts them into molecules of bicarbonate and H+. The H+ then gets pumped out into the lumen of the stomach via the hydrogen potassium ATPase pump. The bicarbonate then goes out into the serum via a bicarbonate chloride antiporter. And what this means is that when you eat a meal and you generate lots of H+, you also generate lots of bicarb, which goes into the serum. And this is called the alkaline tide. If you measure the bicarbonate concentration in someone who's just eaten a large meal, you will see that it rises slightly. And the reason it rises is because of this mechanism going on inside of parietal cells to create the alkaline tide. There is a tie-in with renal physiology that has to do with the parietal cells, and that occurs in the setting of vomiting. When patients vomit, they lose the hydrochloric acid that is present in their stomach contents. As a result, the parietal cells increase the production of hydrochloric acid, and in doing so, they generate bicarb via the mechanism I just showed you. This causes a metabolic alkalosis, and vomiting is one of the causes of metabolic alkalosis, and this is because of the carbonic anhydrase bicarbonate production that occurs in the parietal cells. In addition, patients who are vomiting will lose chloride in the hydrochloric acid in their stomach. As a result, if you measure the level of urinary chloride, you will find that it will be relatively low. And the urinary chloride is a useful measurement when patients have metabolic alkalosis of an unknown cause. If the urinary chloride is low, that suggests the patient has been vomiting because they're losing the chloride in the gastric secretions, as we have been talking about from the parietal cells. If the urinary chloride is high, this is what happens when patients are taking diuretics. Diuretics block sodium chloride resorption, so there will be a high urinary chloride. And a classic board scenario that you should be aware of is a young woman with an unexplained metabolic alkalosis. She has a low urinary chloride, and the diagnosis is surreptitious vomiting from an eating disorder. And you can diagnose the surreptitious vomiting by the fact that there's a metabolic alkalosis in the setting of a low urinary chloride. Now let's go back to the parietal cells and talk about exactly how those different substances stimulate secretion of hydrochloric acid. So acetylcholine binds to the M3 receptors, as I told you before, gastrin binds to the CCKB receptor, and histamine binds to H2 receptors. And all of these stimuli of parietal cells directly activate the ATPase to secrete more H+ ions into the lumen of the GI tract. There are two naturally occurring substances which can inhibit the parietal cell secretion of hydrochloric acid. Those are somatostatin and prostaglandins. I talk about somatostatin in the module on GI hormones, and somatostatin and prostaglandins both bind to receptors and then inhibit the H+ secretion by the ATPase pump. The second messenger systems of the different stimuli and inhibitors of parietal cells have been fairly well characterized in the basic science laboratory, and they like you to know something about these for step 1 of your boards. So acetylcholine and gastrin work via GQ proteins with an IP3 calcium second messenger system. I've shown that here. Both acetylcholine and gastrin can activate the GQ protein, which then stimulates protons to be pumped into the lumen of the stomach. Histamine and somatostatin and prostaglandin all work on a cyclic AMP GSGI second messenger system. Histamine increases the amount of cyclic AMP, which then activates this pump here, and somatostatin and prostaglandin inhibit and lower the levels of cyclic AMP, and that decreases the activity of the proton ATPase. Here's a more detailed depiction of the second messenger systems. Acetylcholine and gastrin work on a GQ protein system. GQ proteins activate phospholipase C, which converts PIP2 into IP3. PIP2 is phosphatidyl inositol biphosphate, and IP3 is inositol triphosphate. IP3 will then stimulate calcium release, and the calcium will activate proton pumping into the lumen of the stomach. Histamine, prostaglandins, and somatostatin all work on adenyl cyclase. The GS protein, which is activated by histamine, activates adenyl cyclase and raises the amount of cyclic AMP. The GI protein, which is activated by prostaglandins and somatostatins, will inhibit adenyl cyclase, and this will lower the level of cyclic AMP. And then the level of cyclic AMP inside the cell influences the activity of the hydrogen potassium ATPase pump. Many of the acid-suppressing drugs that I discuss in the GI pharmacology module tie in with the physiology of parietal cells. So histamine or H2 blocker drugs like cimetidine, ranitidine, famotidine, and nizanidine all block the histamine receptor, so the histamine can't raise the cyclic AMP level and activate the proton pump. Misoprostol is a rarely used drug that is a prostaglandin E1 analog. It will activate the prostaglandin receptor, which will decrease the amount of cyclic AMP in the cells and then lower the amount of acid production. Besides parietal cells, there is another important secretory cell type in the stomach, and those are the chief cells. These are also found in the gastric glands. They're also found in the mucosal layer in the lamina propria. They tend to be more in the deeper layer. They are dark colored or basophilic, and you can see there are more dark colored cells here in the deeper layer of the lamina propria. And if you zoom in, you can see these purple cells right here. Those are chief cells. And the important role of the chief cells in digestion is to secrete pepsin. Pepsin digests proteins just like the enzymes that come from the pancreas, chymotrypsin and trypsin. Pepsin is released by the chief cells, as I said. It's released as an inactive structure called pepsinogen, and pepsinogen is activated to pepsin by the protons in the stomach. It works best at pH 1 to 3, so it works best in the stomach where the pH is very low. And the stimulus for the release of pepsin is the vagus nerve. So when you are about to eat and you're thinking about eating, your vagus nerve gets activated and it stimulates the release of pepsin into the stomach, so it is waiting to digest the proteins that you consume in your meal. And that concludes our module on GI secretions.